Buenos días. Bienvenidas y bienvenidos a la sexta sesión.
Good morning. Welcome everyone to the sixth session of the International Virtual Forum on TB 2022, called FoVI-TB 2022. Before we begin, I would like to inform all the panelists and attendees that this session is being recorded and is streamed on Zoom, simultaneously on YouTube, Facebook, and Imagen TV UABC channel. We also have a YouTube channel in Spanish, which is Divulgare ECS UABC, and another channel in English, which is Remi TV. Transmission of this event in the different channels is done thanks to the support of the Study and Addition Production Center in UABC, to whom we appreciate and thank for the support. This forum is conducted thanks to the support from different institutions. The Health Science School, through the internationalization program by the Baja California Autonomous University. The Mexican-U.S. Border Health Commission, the Binational Thematic Network for Border Health, the Multidisciplinary Network of Tuberculosis Research, REMI-TB, the National Center for Preventive and Disease Control and Preventive Program by the Ministry of Health in Mexico, and the National Network for the Research, Prevention, and Control of TB in Mexico. This International Virtual Forum 2022 has a purpose to generate an open channel for scientific innovation and biomedical collaboration at international level, as well as national level, regarding prevention, diagnostics, and treatment of TB, with a purpose to meet the goal established by the WHO to end tuberculosis. This strategy wants to reduce 90% the number of deaths due to tuberculosis and 80% the incidence rate of this disease by 2030, regarding the base values from 2015. Tuberculosis, unfortunately, is still one of the infectious diseases more lethal at a world level. Every day, over 4,000 people die of tuberculosis, which can be translated to 3 deaths per minute around the world. It's important to remember that TB can be cured if detected on time and the treatment is completed. Likewise, we would like to remind everyone who is here that we'll issue some proof of attendance. So please check the terms and conditions on remitv.org. Also, for those who haven't logged in yet, go to the same website and you will have a link to log in. Or you can also use the QR code that will be on screen throughout the presentations. You only have to log in once. I would like to introduce the first panelist for the session, Dr. César Ugarte-Gil, who is a doctor graduated by the Peruvian University Cayetano Heredia with an MSc in epidemiology by the London School of Hygiene and Tropical Medicine, and PhD in global disease epidemiology and control by the Johns Hopkins University. Dr. Ugarte-Gil's interest is studying diagnostics for TB and comorbidities, specifically diabetes and mental health. And since the last 2 years, he's been working on SARS-CoV-2 diagnostics and influenza. Today's presentation is integrated molecular diagnostics for TB and COVID-19. Doctor, you have 40 to 45 minutes for your presentation, and at the end we have about 10 minutes for Q&A. Okay, thank you. Thank you for the invitation. I'm going to share my screen right now. This is what I'm going to be presenting today is a work that has been going on since 2020 in collaboration with McGill University in order to find out doses to integrate molecular diagnostics for COVID-19 and TB. So this is who we have been collaborating with. This was issued a couple weeks ago, the latest global tuberculosis report. And from what we have seen is that there is an increase of cases in the last 20 years. And this is mostly because of the pandemic. in the COVID-19 pandemic. When we started going through this report and realized that the case notifications dropped. And in each one of you, whatever you are, you know this very well firsthand. Have knowledge of this, that between 2020 and 2021, there was a large drop of notifications. And that in some cases, you're still having a hard time trying to get as many notifications as we were getting in the past. Not every region around the world have been going through the same drops, but we can see that, for instance, in the case of the Americas, that we were doing very well in the past, we see that it has been a big drop, very steep, and the same happened with the Southeast Asia and also in the Pacific. But all this has derived from the pandemic. In the case of Peru, which is where I'm from and where I work, and there was a big drop. Before the pandemic, Peru was seeing very positive results in terms of dropping the detection gap. Unfortunately, since 2020, March 2020, March 13, when we had the first lockdown, primary health centers were shut down, and the diagnosis in Peru for TB is mostly done in these centers. So having these centers shut down, and the fact that people were very afraid of going to health centers at the time, so we started to see this big drop. The gap became larger, and we estimate that about 8,000 people, over 8,000 people were undetected, went undiagnosed during this time. And it has been still going to even today. We have been having interventions in order to drop this or reduce this gap, close this gap that was created during the pandemic. But unfortunately, we know that if it has not been detected in time, they are still spreading the disease at their homes and in the community. And in the case of Peru, we realize that in Peru, that in the countries that usually have most problems with TB are those who have been most impacted by COVID-19. We saw the countries that had the highest numbers of death, and then we see a correlation with those countries that had a big drop in TB notifications. So we realize that there is a big relationship for this in these two values. So there has been a problem, the detection problem. We have had a problem with this gap in diagnostics. So that's something that needs to be addressed. And so what are the challenges that we are identifying in order to integrate this? We have two different kinds of samples. Unfortunately, for TB, we have despite the WHO is promoting, we're trying to get different
a través del uso de hisopados en boca, que sea a través de unas máscaras para poder recuperar aliento, etcétera, etcétera. Varias tipos de muestras, pero que no dependan de su...
Okay, I'm back. Sorry, I had some technical difficulties. Okay. Because of COVID, we depend on the different possibilities, different nasal sample or pharyngeal nasal. So how can we be more efficient, make this more efficient? And now we have some platforms that you are familiar with, where we can work on different viruses and bacteria at the same time. For instance, in the case of Expert, which is the equipment we use for this kind of a study, we have some cartridges that allowed us to come up with different tests in a single sample. And for the case of TB, we could even see if there was XDR resistance, which is a cartridge that was recently released. So this allows us to identify with a single sample, different steps But the point is, what can we do for TB and patients also have some symptoms that are compatible with COVID, so we had to take 2 samples. So we want to see how complicated this could be. And another thing that we had to address for the diagnosis challenge is a discussion that we are having right now recently for those of us working for TB, is that the person needs to be the center of the diagnosis. Because so far, unfortunately, the diagnostics are thought in order to be worked around the healthcare system, and not around the patient. So we know that state institutions rather have large equipment in reference labs. Well, we know that we need to bring diagnostics to the people close to their homes and their workplaces. So we need some simple. We need something very simple. And that's and that was WHO was saying back in May, when we had at the peak of the pandemic, that we need to continue TB services open. That has been a big challenge for us. And in the case of Peru, we still had experience in June, July, that all these healthcare centers were shut down. So it was almost impossible to get diagnostics. And what has been the impact of such a situation? We had a publication last year that they were assessing the impact of COVID-19 on TB cascade, and that what COVID has led us to is a larger infection of TB, and also has led us to less access to diagnosis. So not only in Peru, but we have seen this around the world. So this is something that needs to be taken into consideration when we start seeing that if I don't have a good approach for detecting and diagnosing TB, then we're going to have an impact downstream. So we know how difficult it is. We know it's not easy to know what the effects will be, but it definitely is going to have an impact on the vulnerable populations, and we are already seeing that. And that is where we need to start coming up with solutions and see what kind of instruments, what kind of system I need to use, so that in the next pandemic we don't go through the same situation. Or in this case, how can we close the gap that we have now? So one of the things that we have seen is that TB resources, I don't know about the rest of the countries, but in Peru, we still haven't gotten all the resources allocated to TB. We used to get much more funds and resources, and now they had to be diverted to COVID, and that's made things more difficult for us. It's hard for us to close this gap. So before I begin with the results of this, I want to put the context of in Peru. We had a population of 33 million, and Lima was the region that with the highest prevalence for COVID, and also is also the highest with the highest TB prevalence in the country. So this led us to have a crash between these two diseases, because in some cases, a lot of cases with COVID, and historically there were many TB cases, and not only sensitive to tuberculosis, but also multi-resistant TB. So when we came up with this project, and we presented it with the McGill University, and we said, okay, we have a platform that has been used for many years. As you can see, our experts can see on the left, these are very old. This is their old equipment. That's what we used for the validation expert test back in 2009, 2010. And so we can use this platform that we are familiar with, and we can try to integrate diagnostics in a single platform for TB and COVID. So the first objective was to try to determine the accuracy of expert for adults with TB and COVID. but it was back in 2020. We didn't have much information. So the second objective was to determine the feasibility of coming up with differential diagnostics for TB and COVID with a simple respiratory sample to be used in the expert cartridge and on either cartridge. So this is what we did. Where did we do this? We did in 3 areas of Lima with high TB prevalence. And also there were many cases of COVID-19. It was a 2 second level hospital and 2 health centers that allowed us to have certain representative of what's actually happening. We enrolled about 600 people. No, my bad. No, there's a wrong. That's a wrong piece of data. What we did, we collected information, and this we do a smear, and we had a PCR test for COVID-19 and a expert cartridge. And then we did a sputum sample on which we did PCR and expert for COVID-19 and also for TB. So as a golden standard, we did a liquid culture. So what we saw in these 600 people that were evaluated, okay, we then saw that most of them were male, that as we was also seen during the pandemic. Most of them were men for COVID and TB. They were middle age, between 29 and 54 years of age, and they were not severely ill. Their disease was moderate. Most of them were non-smokers, and we saw that 50% of them in the X-ray shown some abnormalities. Among the most popular comorbidities, it was heart diseases, asthma, and diabetes. That also coincide with COVID-19 comorbidities. And some of the most frequent symptoms were definitely cough. It was frequent cough, trouble breathing, fatigue, headache, sore throat, and sore muscles. So those are the most popular symptoms. So as you can see, these are characteristics that could be easily mistaken. Obviously, cough for less than 2.
Pero también en la experiencia que tenemos, varias personas que tienen tuberculosis registran, dicen que tienen una tos.
That people have a short cough, but when we do we'll go deeper in the research, we see that they have had a longer coughing episode that they would consider normal when it wasn't. So when we did some screening for COVID-19 and TB, we saw that 30% of the population had gave positive to COVID and 19 to TB. We could see that one of the things I want to show you was how this molecular test for COVID-19 with any positive results, we could see that 105 were identified on either test, but whether with an expert or also with a sputum on expert express, a sputum on PCR, and the swab. The idea behind this is we wanted to see how can we simplify the diagnostics. Taking 2 samples is going to be complicated. We have only a same kind of sample. Maybe I could capture the participants better, capture them. So what we saw regarding the sensibility and for the expert express in this kind of test we started comparing expert express with PCRs, and we had a sensitivity of 90%. When we compare this against the PCR sputum, and then it would drop a little. When we combine them both, it would go a little higher. The interesting thing is that sensibility, when we see the COVID cartridge for an expert express in sputum, is pretty high. It tends to be pretty high. Whereas when we compare the last one, we see expert express in sputum versus PCR in real-time CPR, and then sensitivity could be up to 98%. And what is it that we found? When we take a single sample that we use to diagnose, for diagnosis, 83% of the COVID-19 cases were diagnosed through this sample, and 98% of the patients with TB were identified with this. So what you see is that probably sensitivity is not as good as PCR. But if we don't have many cartridges and we have staff shortage and the participants come from a high incidence of TB or respiratory disease, we could evaluate the possibility to do something like this. So why is it that we think this? Because the COVID-19 and TB pandemic have given us opportunities. And I don't know if the electronic registration, we don't have yet clinical background in electronic format. And the only program that had all the patients recorded was the TB program. When COVID happened, we came up with a similar system that what this allowed us to do was to see and realize that there were many cases in this that had COVID and TB, or there were TB patients that caught COVID on patients with had a TB background, and then they caught COVID. And why was this important? Because we realized that they had higher morbidity, those who had TB history. So that's why it was so important to come up with a good diagnostic. And to wrap up with, one of the things that we realized when checking the literature is how can we do? Because literally having a sputum sample, yeah, it's good. It could be a solution, but not always we're gonna get this. We don't have expert in every center, and we don't have all the equipment in all the centers. So Global Fund came up with a brief report with some recommendations. So we had individuals with TB, or when we're suspect of TB and COVID-19, they were required to get some apheresis, and then from there we would see what the best diagnostics method was for the screening. So, but we need to collect sputum for TB. We know that's not the best test. Not all the centers, they have molecular test equipment for TB, unfortunately, and we saw this the labs in the case of the labs didn't have enough capacity for diagnosing all COVID cases. So simultaneously, one of the things that we saw in countries with high load in a recommendation with USAID and STIP-TB was to try to come up with these parallel diagnostics. So that's why we were considering that the use of a single sample could be a great advantage. And if we go back to the fact that the sputum may not be the best options, there were some barriers that we had to take into consideration. Having a molecular test such as expert, and we have seen may have an 83% of capacity to identify COVID and 98% for TB. It doesn't mean that we can just it can be implemented everywhere. There were some cases that we saw during the pandemic. It was hard to get expert cartridges in countries such as Peru. I don't know about the rest of the world, but there was a shortage because they were sent to the US and in Europe, and so it was hard for us to get them here. Despite the fact that we had equipment in Peru, Peru had already installed 30 pieces of equipment throughout the country in order to identify HIV and viral load in patients. And so we had a platform, and we tried to purchase cartridges, but it was not possible because they were sent to the US and Europe. So we came up with this research and having all the platforms available here in Peru, and maybe also in other countries that have problems with TB, you may have these platforms. However, we need to take into consideration, especially in the pandemic times, the problems we have, the barriers we have to the access to this equipment. So one of the lessons that we need to be learned is that despite the fact that we see a drop in TB detection, as it could be seen in the WHO report issued a few days, COVID-19 could be a possibility for us to increase the diagnosis, but close to the people, close to the population. Having very complex labs and lab tests, it only creates barriers for the people to be diagnosed. It's important to have referential diagnosis for sure. We need to do them for surveillance, for detection purposes, and retention, resistance tests, and so on. But if we want people to be treated promptly, we need to bring all this to the people. And that's what we need to see. That diagnosis cannot be in silos. I don't diagnose TB. I only do COVID. But no, that we shouldn't act like that. We need to do them all. In many countries such as Peru, everything was working silos. So it was only the TB program, and I don't see anything else. This is only for diabetes, and I don't see anything else. So no, we need to see how we can integrate the healthcare system, maybe through electronic records and different platforms that we use in order to integrate in a single sample the diagnosis for the different diseases. And that is the way the patient spends very little time at the clinic and then can go home with their test done. But if we send these samples to labs, it takes up to 2, 3, 4 days, and then we can lose the patient. So I just want to thank the staff at the university, Dr. Francisco Espinosa, Dr. Tatiana Cáceres, Lucia, and Elizabeth Quinto, and the team from the McGill University, Dr. Carpay, Dr. McLean, from which was part of her thesis, Dr. Sundis, Mika Shilikoli, and Caroline Bagnice. This research was sponsored by the Canadian Institute of Research, and it was. I don't know if you have any questions. We want to thank Dr. Ugarte for his interesting presentation. Now we are open to Q&A, to a Q&A session. So Dr. Ugarte, we have a question for you, which is if we have only planned to increase those reference points for the diagnosis that you just mentioned. You mentioned 3 that were done. Is there anything, is one in particular that you would like to add or elevate, or there is some inconvenient in order to increase those reference points? That's a good point. We use these 3 sites, those 3 clinics, because we had been working in the past with them for TB. So we knew that they were high rates of TB in those centers. What happened in this when we finished this research a couple of months ago? So the national TB program is launching campaigns in different areas, doing the same, trying to through the antigen test and for COVID and expert for TB. No, not with using a single sample, but with two different samples, as I showed you, the algorithm that would suggest global fan and a stop TB. But what this has allowed us to do is it has allowed us to so what are we doing? What we're doing right now is we see looking at different strategies. Right now with McGill team, we are about to start a study that we already have the pilot phase for this for using AI to detect cough. There are some coughing patterns that are more they are closer to pneumonia, COVID, and TB. So we want to see if we can discriminate through an app on the phone that could be keeping a record of all the coughing patterns for the screening of the different diseases. Thank you, doctor. We have another question. The combined strategy for detecting COVID-19 and TB seems to be very successful. But how can we do this with a drop of COVID cases? Because we know this is going to happen. COVID is going to drop and then influenza is going to go up. I don't know about the rest of the countries, but we see here identifying more influenza cases now, influenza B and influenza A. So what we need to understand is that the diagnostic systems, they should not be working in silos, because we need to see how we can make a screening more efficient. We have to screen for all the different viruses or bacteria. So sometimes it's difficult in primary healthcare centers. It's very hard to have very sophisticated equipment for this. But if we maybe we can come up with algorithms and say, okay, to this person, I'm gonna do an antigen quick test, and if it's negative, and then we're gonna follow this protocol inside. Another thing that we learned from COVID, despite the fact that we see a drop in the incidence of COVID in the last 2 years, it's going up a little here in Peru, is surveillance. I think that what we have seen with this pandemic is that the surveillance programs need to be active at all times. Unfortunately, that's not the case. That didn't happen here, and they need to be very well implemented and well distributed throughout the country. Okay, thank you, doctor. We have another question, which is, was the disposition for the national TB program to implement these two tests? The national TB program is migrating everything needed to implement by molecular methods. We want to decentralize it. We see them in the last weeks, they have been trying to implement the new expert platform, 10 cutter with 10 cutters to be able to use the different cartridges. Because in Peru, we have a high resistant problem. So since we have the results in 45 minutes, the idea is that the patient will get quick responses, answers to. We can, it's not, I mean, sending the samples to the labs and waiting for weeks to get the results back, then we're going to lose a patient meantime. So we want to implement this. And there was a similar effort before the pandemic, but even more important right now. One of the things that we need to say is that we need to take into consideration in Peru, it was one of the sites that we used for the implementation of this expert validation. And the article that was published in New England in 2010 in the institution was part of that research. But since 2019, started buying equipment at state level. Why? Because we had the idea that we need to have in the reference labs centralize the handling of of resistance diagnosis, something that, once again, the pandemic, something that has shown us is that we need to have decentralized diagnosis and closer to the people. Very good. The next question is, in which other countries is this double test is being implemented, and what's the impact seen in those countries? I don't know exactly. I know there's some research done in South Africa and India, I believe so, but not using a sputum. They just implementing 2 different samples for expert and COVID. Let's remember that expert in many countries is the most popular testing method for TB. In the case of COVID, it was one of the cartridges that had high sensitivity. So it was very helpful for different problems being able to implement this diagnosis. But once again, the problem is that platforms may be available, but if the cartridges never come in, which is what happened during the pandemic at some point, because they sent all these cartridges to the US and Europe, so it was very hard for us to control the situation. Great, doctor. There is one last question for you. During the screening, have you identified patients that suffer from TB and COVID-19? And if so, what was the treatment for them? And how's been the follow-up for their patients and their treatments? Yeah, we identified there are 18 or 14 in this study that they were positive for both. So not in this cohort, but we are having another study that we're doing with the national data that it has a higher morbidity. Unfortunately, it's because many of these patients, TB patients, they had some lung damage. In the case of the patients in our study, fortunately, they were all okay. None of them were hospitalized. But we said at national level, there was a little increase morbidity for patients with COVID and TB. Okay, excellent. And another question. What would be the strategy in TB to identify subclinic and early TB that we know can be seen in at least 50% of the cases around the world? Yes, we have been discussing this with my team. What would be the best strategy for this? The problem is that we don't have a good test. I don't know if you remember, but for me to remember to identify active and latent TB, because now we decided that when tuberculosis in a spectrum, we need to have a bacillium load very high. So when we talk the clinic and early TB, we're talking about people who do not have enough load yet, but they may have some symptoms, but they don't have enough. The load is not big enough. Unfortunately, the diagnostic texts are not as good for these cases. In the case of IGRA use, we could come up with a strategy, but unfortunately in Peru is very expensive and it would be very difficult to differentiate if it's actually something that is, if it's a contained case in the patient or if it's a clinic case. We expect that in the coming years we're gonna have a great discussion on how we can identify as a clinic TB and how we treat it and diagnose. Yeah, because how do we treat as a clinic TB? Are we gonna follow the old-fashioned treatment, or we need to come up with something new? So it needs to be, we need a lot of discussion on that. Okay, thank you. This event is being promoted by PACMO with offices in Ensenada, Tijuana, and distribution through nationwide. Also, the Nissan company, which is headquarters in Guadalajara and offices in Ensenada and distribution nationwide.
Ahora le damos la bienvenida al
Now
doctor.
we welcome Dr. Patricio Escalante, who was graduated by the Peruvian University Cayetano Heredia in 1991, completed his residency in internal medicine at the Henry Ford Hospital in Detroit in 1995. And his formation on lung medicine and critical care and sleeping care and by the Baylor College of Medicine in Houston. In 1998, Dr. Escalante has a science master's degree in biomedical and clinical investigation by the University of South California in 1917, and basically has been focusing on TB and mycobacterium infections, non-tuberculosis, mycobacterium infections. We also have our 01 level funding in order to research new immunodiagnosis for infections with MTB and other, and collaborates with other professional healthcare professionals, is biomarkers for latent tuberculosis infection and niche. And you have, Doctor, you have 40 to 45 minutes for your presentation and 10 to 15 minutes for Q&A. Thank you. Thank you, Dr. Raquel Muñiz, for the invitation. It's a pleasure for me to be here and to share a review of latent TB, particularly the new biomarkers and some of the work that has been done here in the clinic to be able to contribute with to identify and validate some markers that could be useful for the clinicians to be able to say latent TB and early TB and maybe some clinic TB. So I'm going to share my slides with you. All right. So the purpose for this talk is to talk about the emerging concepts on TB infections, especially for after Dr. Ugarte's great presentation. I think it's pertinent to discuss a little bit about early and subclinic TB that we know is highly frequent in some cases, in early active cases, especially we estimate that 50% of the cases have these characteristics. And talking about the new biomarkers that are being developed at different levels, and also my own bias, what could work, and also to infer the risk for individuals that have latent TB and that could emerge on progress to active TB, and those markers that could be able to differentiate on symptomatic patients and those who have some latent TB. And how can be used? As Dr. Ugarte mentioned, we may see as a clinic TB case, and we need to know what to do with them. So we're going to show you two cases that will illustrate this problem. And I'm a clinical clinician, and I see patients in my clinic, and I see, for instance, a male, 45-year-old male, and non-smoker, allows asymptomatic. They did a TB test for the 7 millimeters. They had no quantiferon. The physical examination was negative, and they only have some reflux and allergic rhinitis, and the X-ray was normal. It was in 2003, and now he comes back. Let's see if we can make this work. See, 11 years later, so the same man, and now he's 56. Back then he had a TB test, and it has isoniazid. And he didn't complete the treatment. It dropped after 2 months, and that's when it landed. So he had in the US, we do screening all the immigrant patients, and that's why with the indication of treatment and for the patient right away. Now he comes with has been having dry cough for a month, so his family doctor says azithromycin We see if it's a bacterial and atypical, and then he has the same symptoms: no fever, no chills, no sweatings, no weight loss. He only has cough. So he says that he has some sibilance when he goes back. When he lays down, he is diagnosed with asthma, and then he also shows the same comorbidities. So we do an assessing X-ray, and now he works at a college cafeteria. So he's coughing, and he has this latent TB, and then we see a normal X-ray. So the question is, now we do a quantiferon that which is positive, and the question is what to do. What's the diagnosis? Is this bronchitis, or it's a latent TB, or if it's a reactivation of early TB? So that's a clinical question that it could occur in patients with this kind of history. So in our countries, in Latin American countries, we see that many of these patients that they have bronchitis and don't given quantiferon because they have very good amount of patients with high positive quantiferon for a long time. So the same case is a 65-year-old male from Somalia. He also lived in the Middle East, and he back to the US. He moved to the US 5 years ago, and he had no previous TB cases, and as asymptomatic, and he has an occupational screening. He wanted to work with patients at home, and so to be a positive quantiferon. So he's been a smoker. He quit smoking 12 years ago. He has hypertension, osteoarthritis, and well-controlled diabetes. So the X-ray, when we did the screening, we see quantiferon, it was abnormal. And as you can see, it's very in the shade on the right side of the lung. And the question is, what is this? So we did an MRI to be able to see in more detail what's happening. And yes, there is a series of nodules and the upper left corner, and so also some in the back, and we saw some other on the stream back that were not completely specific, but it was a sign of concern for a patient with quantiferon with kind of infiltration. So it was a possibility that this was an asymptomatic TB case. So here the problem is that they had the idea of what's the spectrum of TB throughout the exposition, infection, and the progression to the disease, or the containment of this infection, of this disease. So once a patient is exposed, there is about 30% of the patients, they do a tuberculin reaction after good exposition at home. So what happens is that there is a granulomatous infection by the bacillum in the lung level, in the lung, the complex rank, and then we saw that it goes untreated. So immunocompromised patients, then about 10% of them, they will develop a TB infection, half of them in the first 2 years after the exposition, but there is a 90% that won't. So we know from the data from the 40s and then the surgery that were done in highly exposed patients with latency, said that many of these bacillus were calcified, that there were 30% of those that could culture bacillus. They say pick cuis that were highly sensitive to this. So this chronic containment, it could be eradicate, but also contain this bacillus. And so partially that's the success of TB, that it could be contained for a long time and then emerge instead of the transmission, because it can be transmitted, because we understand that it will be transmitted not only through cough, but also patients with these characteristics, they can spread it by speaking and just breathing normally. It has been demonstrated with very specified research. So within in this stage of this LTB, about 2 to 3% of that were positive will develop TB. We cannot treat all the patients, but this is what we're treating 80 patients before preventing a single case, assuming the incidence rate is 2%. So we need tests that tell us who these 10% are that more likely will develop TB and focus on them. And that's what we have been working on. What we know, so through this test, the new tuberculosis do not differentiate between active TB and LTB. There is no way to do this test, and they had low sensibility. They always said when immunocompromised patients, they may have some variability. These are biological tests. There might be some more reactivities to this kind of test. It has been seen in some health workers, and the predictive value for this tests are low. So only 5% of the patients will progress to active TB. So the new quantiferon tests, they have a similar diagnosis accuracy, but they have a risk inference. There are new tests that are being done in different sites of the world, around the world, and to make this test much faster. And I'm not going to elaborate much on this, but I'm going to tell a little bit on the development that we're seeing. But we see that there are some tests that we see that are very promising, but we need to see some validation tests and in different populations to see if they actually work, and see if they can be implemented in low-income areas, as Dr. Ugarte mentioned. We don't want to depend on the infrastructure or cartridges for this kind of detection at local level. And the new tuberculosis that are being developed are a way to do it. Unfortunately, this tuberculosis may not be more efficient than IGRA test or expert with high LTB cases at high risk of progressing. So we need to improve this strategy. We know that infection of TB is not as simple as in previous cases, but infection could go direct to an activation, when an early activation, a primary TB, but it could be this dynamic cycle where it could be subclinic early TB, and it eventually could emerge. And we should also know that these tests, many of them, these patients, they will be relatively protected. We also know that there are some clinical conditions that make this latent TB could progress. HIV and AIDS is one of them. Incidence is 10% per year. So it's a very important factor. Purely controlled diabetes. Some other situations might affect the immunocellular response. And in many other countries that are malnourishment and the deficiency of vitamin D, there are so many factors that may have this subclinical condition to emerge. Different patients that we can determine some genetic expressions of genetic signatures of ARN that we might identify that a patient is developing a TB. And these are basically genes that have to do with interferon information is a type 1, more specifically, that occur before, months before, even years earlier, before this infection, this TB disease emerges. So the idea is that if we could try this new test, we might be able to identify patients not only with that have been exposed, but also those who are at high risk of, and so because we need to lower the number of patients that need to be treated in order to be able to prevent the disease. So this was suggested for this early TB, incipient TB, because there was no X-ray or indication on blood, we can identify this genetic predisposition. And my term that a patient is a process of emerging TB. So all the same purposes being tested and have been produced in the number to be able to more technically that we see that the closer the case, then more likely that the test will be positive. We have also determined a specific applicability up to 80% 3 months before the emergence study could be possible. So doctors have suggested some titles for done in a more validated fashion. And the minimum for this profile is 75% of countries. And this will include the reduction rate into 6% by 6%. The optimum would be having a sensibility of 90%, which would definitely drop the number of cases that need to be treated to avoid or prevent. Almost 2,000 and there we saw patients with ARN signature. It was J11 that had 11 genes, but it was compared to and then individuals 11 negative. And we saw what was the performance for this risk 11. And it's important you saw that if the treatment of these patients with risk 11 would drop the TB incidence in risk 11 when they were untreated. When the evaluation was the baseline evaluation was done for these patients, many of them, they had an early TB case, and many of them later on developed TB. Unfortunately, there was no incidence change for TB on the treated and untreated patients that had this high prevalence ARN signature, increase the probability of developing TB. This was the chart that showed a positive signature and a negative signature, and there has a difference in 9 months, then 15 months, and then when you had the primary cut, we identified patients in subclinical stage. So when they were symptomatic, the signatures were very clear, they were great to identify this, but when they did not have any symptoms, so these patients, the detection was not as good, was not as solid. The same occurred at the time, there was a closer the time was to the emergency time of the time of emergency actually, the more robust was the results. So with this trial that was supported by this foundation was negative, but we learned a lot from this about the probability. We could also conclude that that treatment, at least latent for LTB, in this case, for early TB, it may not be the best treatment strategy. Maybe we can treat it with 4 drugs. As an active TB might have a better impact on these patients. One of the things Dr. Scriba is that many patients with these signatures, they have false positives. And something that was seen later when they had some viral diseases, they had these IRN signatures with gamma interferon 1, and they could seen with viral infections such as COVID. So this dropped a little their interest in developing these kind of tests. But the concept of the emergency of TB from early to active TB is valid. So I think there is a good opportunity to work on. So it can be diagnosed with hypertension with IRN signatures. Yes, we can, and they work very well. And then even with 2 genes such as BAS2, and it could be very a good predictive tool for patients with latent TB and active TB. But these patients are symptomatic. So I hope you can see this on the screen, because when we do the cut and specificity or 70% the RN signatures, it gives us a sensibility of 85%, which is within the parameters for the WHO for a triage test, minimal test. So as I said, there are some false positives. So this may occur not only in viral infections, but also some pneumonias that could give the same reaction to ARN. So some of these signatures in CD6 has been implemented within the expert cartridges in the pulse response, and in principle in a multi-center trial we do this good with specificity. So the RIG6, which is a little bit smaller, so the in South Africa group, they have some sensibility, but the specificity was not so good. So the question is if this test could be useful for screening, a triage test. 11, as I mentioned, has problems with viral infections, and we don't have enough data for patients with significant disease such as HIV. And also it's important to note that with expert ultra, which is highly sensitive, we can also identify false positives. Yes, there is a risk, and we register several false positives. And the processing for ARN is a little hard. ARN is not very stable, and so there is a window period that the detection, and with the expert in order to change to a different kind of cartridge, do some other tests with an ARN. We need to have an ARN stabilizer. So we have some technical difficulties and limitations to be able to switch for the potential detection of early TB to subclinic TB. As another biomarker that differentiates active TB with the risk. Well, our group has been working for many years on the immunoprofiling. So this gives us more specificity. it makes them more complicated, but if we have more solid tests that could be used as validation tests or as gold standards, and they can be later used for more simplified tests, then these tests, they may be able to move forward to identify early TB cases in the communities. In the New York Journal, we published a work of the detection of with markers for T cell behavior, antigen specific to TB, and some other groups that have been working on different markers. The most interesting, I believe, is HLDR, which is expressed in there's mostly expressed on the presenter cells, but and T lymphocytes can also, this LHDR could be seen, and it's good for identifying lymphocytes that have been activated. This is what has been seen with interferon, and we have seen that it could be used to diagnose among patients with LTB and active TB with a very good accuracy for HIV positive and HIV negative patients, and also there are second curves. There are some other interesting markers. The grade regulation, the CV27, is also interesting that it works in a similar fashion. And there are also that have been published in the HLDR. It's interesting because we have also seen that could differentiate a patient with persistently positive quantiferon versus one that has been recently positive, that infers a higher risk in the disease and a group in South Africa. So the HLDR, this marker with gamma interferon and alpha, they can identify these lymphocytes reactive to specific antigens that have a differentiation in patients with interferon gamma positive. And set this delta for the CDR between the lymphocytes that they're reacting to antigen versus the total. So we have this differentiation in patients recently, converted from quantiferon negative to quantiferon positive, and versus those who have a persistent quantiferon positive. And that was done in a cohort that they could compare with patients with active TB. And these patients, these groups, HLDR was not only could be differentiated in the persistent gamma interferon, but also there was very similar to patients with active TB. And in a progressors group, this comparison was done with using a different method to identify this delta HLDR delta. It could predict, we see that it could predict which patients would develop TB. So it was not perfect, but it's very interesting, specifically using the concept and the differentiation with this kind of approach for immunoprofiling can be used for early detection method, as an early detection method. In the La Jolla group or now some other groups, they have been searching and saying what does this HLDR expression in the lymphocytes is. It said it's a marker of a division of lymphocytes, very recent, particularly in lymphocytes that have been pre-exposed to TB. As usually the concept of that someone has been infected, but they have microgranulomes that are still active, and they are issuing these antigens. If we see that everything is well eradicated, so if they're not active, they may not have release of these antigens, and they won't have lymphocyte stimulation, and eventually in months, these lymphocytes and these lymphocyte groups will be greatly reduced. So this HLDR is very interesting. And it was seen in this trial that it could differentiate patients with active TB. This is error positive and error negative, and then there are some other markers that also differentiate between the latency and PD1 and X40 and SF25, which are markers that have been studied, unlike other markers that have been published that may have the potential, but at least in this comparison with this marker, it was shown that being is very specific for the, so that other markers are not as good. The same group came up with a genetic evaluation of this, and we saw that yes, the stage 5 or X40 can also differentiate this one measuring the division. Other groups have also seen that the co-expression of these surface markers, lymphocytes, have this specificity, but not only to TB, but also other infections, maybe sensibility or not to vaccines, as we could see here in patients that had been vaccinated against tetanus, and when these lymphocytes are exposed to the tetanus antigen, they are very responsive. So it's interesting to see that how these lymphocytes and these markers that have a Treg function, that is also very important for the working of the granuloma that we are learning a little bit more of in recent years. Our strategy has been to try to see if this latency strategy could give us an idea of what the more important markers are to identify which patients are at high risk. No, the hypothesis is that in patients that have this active granulomas and that could progress to TB, and if we do treatment and we see that these granulomas will eradicate their bacillums, and they will become cold. However, there are many patients that have gone through this natural process and they don't have the risk, despite the fact that they already have a positive TB test and positive IGRA, but their treatment will not change because those bacillus are dead or they're highly isolated, they have been calcified, and they won't become active. So the hypothesis is that if we can identify the markers that change with the treatment, they could give us the inference of which risk markers are. So for patients that have been treated at least in this area of the world with low transmission of TB, it confers a protection status, because these treated patients, they have an efficiency of 80% of not developing TB. So having a good profiling for this kind of patients, the treated patients, it gives us a possibility of protection. We did a benchmark a comparison trial that is the patients that have not been exposed, those with quantified detected patients that have been exposed to TB, but it was not differentiate those that have been treated, same as the strategy with the spot. It could differentiate those that have been unexposed to those that have been exposed, to see a difference between the treated and untreated, and then we would apply a detection of this kind of surface markers with the same kind of specific antigens. We identify that there was a differentiation between treated and untreated patients for detecting CD4 using this kind of markers, CD24 and X40. And this was not the case for the PPD or PPD reaction or the candid reaction. So we also did an evaluation of this kind of detection CD8, and there was a change in the CD8 with this lymphocytes, exposed lymphocytes to PPD. It was very interesting because it's a protein and has antigen response to ACA. So this was assessed using some modules to see what the probability was for the activation of TB in these groups. And so we did with the McHugh group to determine TB risk. When we saw the evaluation of these individuals, this group, both had been exposed and those had not been exposed. When they had the positive marker, or developing the or evolving to the disease. After they had this negative marker with a negative quantiferon, the risk rates dropped tremendously. The same with this CD8 marker, PPD. So this type of approach at least can help us identify the probability, the risk. So we had an evaluation that is about to be published. And so we saw that, yes, these markers, these lymphocytes, could differentiate between the treated and untreated. The same with this SMA, the same results, the CD8 PPD in this validation. The interesting part is that we found that the high lab would go down and treated patients with this independent cohort. Seeing one of the possible factors that might have an impact on this, we're showing this, it was a fact that many of these treated patients had been treated a long time ago. So there was this drop in the interferon response over time. You could see that these patients may develop after many years. So when we did it on the spot with the NTB300, which is a mega pool of most part of the TB cases, we could see that this test could drop lower in the over time in treated patients, also in candida, which is it's not very clear. It's very clear, but when they had a positive test with anti-centrin, there was no differentiation. Interesting enough, there's the CD8 or CD4, but this approach, they also had this drop when these lymphocytes were exposed to this antigen pool. This is to show you these patients. Yes, after many years of treatment, they did this test, and obviously this impacted the results, for both cases. So we see the type of responses, so there was a differentiation between the treated and the treated. Was with the CD in PD1, very close to the exploratory markers. We have been, in the last couple of years, we have been doing tests with HDR to see how effective the approach is to determine treated and untreated patients with LTBI. Now, we have seen that our data are showing that effectively, the approach can negotiate with patients that are exposed to multiple patients. But no, at least at this level, we cannot differentiate very well between those that are treated and untreated. The exam differentiation is possible with a lymphocyte test. So to this mega OTB 300, which may determine the differentiation between these treated patients. We're analyzing how long has gone by since treatment to be able to do that. But the dynamics are so beneficial in areas where the exposition is repetitive. Another thing that we have been developing is we're looking at the identification profile. We know that once TB has been exposed, and lymphocytes have been exposed to these antigens, we saw that there is a release of interferon gamma and alpha, but a series of other cytokines and other mediators that directly or indirectly may circulate and may give us better information about the state of their immune response between the two. So we have seen that in a multi-centric trial, that this kind of approach, this kind that TGF, alpha, clean beta, and the supernatant consequence to be differentiated with a diagnosis precision of 81% active TB versus other respiratory infections, depending from HIV. So there is a possibility of this kind of diagnosis, this kind of biomarkers. This group from South Korea saw that they did the epitime, use epitime, especially the differentiation with antigen. Specific RE1, which is the one that produces this epitime, and compare the nitrogen to differentiate patients with latent TB from those with active TB. We have done this trial where we selected the ratio there to from gamma with this in this cells exposed to PPB. We could differentiate after and along the exposition. So these are not tests that can be done quickly. They require the ISR and the infrastructure, but we see that there is something that this differentiation can be done. There's a concept we could apply in much faster tests. We have seen with groups in the University of Michigan that have been developing in particulates and some other sensors that they could show this cytokine in real time with high precision and develop this in the microchips that are very, very, very cheap, very low cost, and that could be read later on. And then see if we have these patterns of the signatures that could be specific to identify between LTB and FTB or their high probability of progression. This has been applied in the quantiferon plasma, and we have seen that virtually there is a high probability of progressing to TB. This data is in process of being published. There are many groups around the world. There is a 5 group. They have this very well organized. They have very good progress on this. So I think that the field is gone. We're moving forward to be able to develop technologies that detect patients before they develop the disease and be able to differentiate those that have been exposed, that are highly likely to progressing, and versus those that are not likely to progress, and those are protected because there's also that possibility. And as I said, FIND has this follow-up. There are different ways of doing this, not only through these methods, but also within other technologies. Some of them are similar to what we have developed. STEM-TB is a good profiling, but there are others that are working. The new technologies are very interesting. It's also interesting to know that the peptides that are identified in TB that could reach circulation and mix with proteins from the serum, from the serum, can be detected with nanoporous technology, and they will be able to identify them clinically and be able to differentiate patients. TB patients have positive and negative culture of TB. So it's important to see there is a new concept and these technologies are still very expensive. And I don't think we're quite there yet, but the concept that there is this kind of screening for antigens, this could be a good, interesting tool to also identify this in clinic case and clinic cases. So to wrap up with, let's go back to the patient of the Laos patient that had an agra and had cough and it was working at a college. And they did more evaluation on him and they effectively, yeah, he had, it was not early TB, it was subclinical TB, but with some X-ray tests, we saw that some indications of TB that led us to think that this person was developing a very early stage of TB. And yes, we did 3 spotums tests, and one of them was positive to TB. We gave him treatment, and he was isolated. And if we avoided the transmission in the college, that could have been, people might have thought they had bronchitis, and there was not a high risk of spreading the disease, but it helped us see that the patient could have had a viral infection, and maybe that infection could have had this imbalance in his LTB, and that they might have potentially created a good environment for this to emerge and to spread it within the community. So this thing is to illustrate that the fact that we need faster and more efficient tests for early detection. The man from Somalia was asymptomatic and then had X-ray indications and they are positive IGRA. And we did this put-on test and smear, and we had a PCR, and it was all negative. And this patient was subject to treatment with 4 drugs. And yes, over time, this infiltrates disappear. It was as a therapeutic treatment for this patient. And also illustrates that this test, that including PCR, are not highly sensitive for TB, so clinical TB. And we also need some blood tests or some other kind of tests that are more efficient. This kind of patients. So I think we're making good progress in this regard too. So I think the strategy of detecting and having diagnosis help with AI, and that could also be transmitted to normal clinical practices that might detect some red flags that this patient is highly likely to develop TB. And they can be screened right there and derived to the different offices where they can be, if it can be helped, can get assistance to reach beyond those patients that have to be referred to the clinics. So there's some other interesting data, such as some exhalation tests for volatile molecules detection, also for coughs. And another way of screening is by analyzing the coughing patterns. Is there something that will be seen in coming years? Well, this is going to be included within our own environment. So to conclude with, I would say that one of the TB biomarkers, they need to be better than what we have now. They have to be good for detecting patients that are going, not only those that are going to go towards TB, but also to differentiate from those that are not going to develop TB. So we can do the right follow-up on those patients and also be able to identify where these granulomas that are inferior, those that have been highly contained. So the idea is having markers that have a good capability to lower the number, to reduce the number of patients that need to be treated, to be able to prevent actual TB cases. So here, what I'm trying to summarize is that the new blood test should infer low risk and high risk LTB to be properly handled and treated, and also be able to highly detect patients with clinical TB because they will be diagnosed, and these are very frequent among our population and patients that are being lost within the communities. So these markers, they need to have a differentiation between general TB and active TB and other conditions that may be very similar to these cases. So the diagnosis of early TB will be a reality with these tests. So we need to change the diagnostic strategy. What we're going to do when we get a positive, and then how we treat them. You see in the court is that treatment with the normal latency, some things were not working, even though there might be some things for the interpretation. See that we use all 4 drugs for 4 months at least. Patients with culture negative TB could be treated with a properly X-ray follow-up. The problem is that in some cases where there is so high drug resistance, what to do? So we have adenosine resistance is not a problem, but when we have a rifampicin resistance, it's going to be a different story. So this will allow us to improve the transmission cycle of detecting TB before it spreads to the community. And also the subclinical TB diagnosis, and something that needs to be seen from a more global and triage approach, triage and clinical visits, and how this is going to be derived to a more specific treatment. And the experience of Dr. Ugarte and other investigators have seen how we're going to get there. And also, we should not forget about the therapeutic test, because we need better tests, that's for sure, but because we have multi-drug resistant cases, then those patients are not going to improve. What's the cost for this? Look, how we can this be implemented is very important, because we want to be able to implement all these strategies and how we're going to do the evaluation. And I think all this is very, very important when we have these new markers that are being released. And so we need to have more validation trials in different populations, different groups, different countries with different kind of strains. There is a lot to be done. I would like to thank the investigation group, not only in our clinic, but also the group of Michigan and other groups that have been working with us, and particularly NIH has allowed us, has made things a lot easier for us. And so as well as Dr. Ugarte, thank you, thank you everyone. Thank you, Dr. Escalante, for your participation and your presentation. And we have many questions for you. The first one is, in cases that you mentioned, the working screening was with quantiferon tuberculin with all the workers, or only when they started a new job, or who were candidates who were selected? Well, it has changed in the US. I can tell you in a low transmission area, now all the hospital workers, they are screened only with quantiferon when they are first hired, and then we have a clinical screening. Then obviously it's limited, but that's what we do in some groups that are highly exposed, and then we work with PhDs. Then we do an annual screening with quantiferon. And then we're using tuberculin screening at least in this. Because many of these workers also come from countries where where TB is prevalent. The group that is doing this is doing quantiferon mostly. When in the past, we would do tuberculin in the past because it's more stable. The readout of tuberculin is more stable versus quantiferon. When the T-spots may give us these false positives and may have 5 to 7% of the cases with no evidence of exposition, and that has been a little problematic for us. Okay, doctor, thank you. Next question. How do we do the diagnosis process for ARN predictive signatures, and as well as a clinical and X-ray test? Do we need further testing before doing an ARN test? And why do you think that we see these false positives? It's a very interesting question. At least in the trials, we did ARN tests at the time that we were doing the clinical and X-ray evaluation. When the CAR test, when they came up with positive, we did the same evaluation. We do use sputum and expert. So in these patients that we have this positive test, I think that's very good because we may have a false positive with a viral infection, but it could also be an early TB when there is no X-ray indication findings, so there are no symptoms, but their body is telling us that it's getting ready for an immune response that may lead to TB, or it's a case of asymptomatic TB. Subclinical, we're going to see there might be a radiological component. In some cases, we need to do some other tests. For instance, in the case of the patient that you told you about it, they have been working with other patients. So I'm sorry. I have a question. How could we implement the use of these biomarkers with high loads of TB and low incomes? That's a big question. So I think these markers, they only giving us to get a concept and letting us to helping us understand what the dynamic is. And so we need to do like the home test for COVID. We need to have a simple test. There are some prototypes for this kind of test. Validated with more validated, so we can determine if there is early TB as a clinical TB, and then maybe refer the patient to more in-depth defect tests. So I think that in those cases, what we see higher loads. So this kind of periods will tell us it will be more useful. The ones we have right now, we don't have the technology for doing this. Although it is being developed, as I showed you, the cartridge for HR, it's one of those that can be used in the same machine that is used for the detection of gene expert. So this is not very clear if it's going to be cost effective or not, and which group we're going to be using this on. So we need to work on different approaches, such as the X-ray side and the AI side. In the case of almost asymptomatic cases. So I hope I'm answering your question properly. Yes, doctor, thank you so much. So the next question. So is there any kind of interference with tests with RNA journalized patients with the TB and diabetes or TB and HIV? Great question. No, there is no good testing for this. We don't know if this is in the case of HIV or diabetes may have an impact on these tests, because we know that, as we mentioned before, viral infections, some pneumonias may give us this genetic expression. It can be identified with these tests. So which way non-controlled diabetes or HIV may do this? With these Texas, because patients with HIV may have other infections such as hepatitis or others that could be probably identified with this test and may give us a false positive. So we need more research to be able to know that's a good way for diagnostics. So we're putting a lot of effort in the method in immunology, because maybe this might be able to help us to have a more specific evaluation of the immunological process. So I think that's what we need, the kind of approach we need for this kind of populations. Okay, thank you, doctor. Next question. Out of all the methods that you showed, which one do you think is the more that gives the best results, and they could be faster and cost-effective implementation in Latin America? Yes, from the ones that I have shown, there are not so many. Like you said, this kind of test, they have very good for immunoprofiling, but these are not easily implemented. So what we're trying to do is to have tests that are very good, very accurate to prevent. But then we need to have some other kind of test that will be validated, and there are already some tests that are being validated with laminar flows, different cartridges that show a PCR. It could be done with normal room temperature. There are some other technologies that are being developed. So I think we are not there yet. If we have infrastructure for quantiferon, then this analysis is very promising. We're working with the Tijuana group, a prospective group, and we are just identifying using the quantiferon plasma for this kind of screening patients at a hospital may have an difference between higher risk or low risk or subclinical TB. So I think that's a good way to be able to see the ARN test. They are very interesting, but we don't have part of these cartridges yet. We don't have any other platforms that could be easily implemented with these in mid-level labs. So you are not there. It's a very good question, but we're not there yet. Okay, thank you, doctor. The next question is about the ARN test, blood test. How long it takes to get results, and when they have to be implemented. It depends. They can be done very quickly. You capture the RN with a special tube the first couple hours, and then we need to have the RN batch. And the problem is it needs to be done as a batch, at least in the research trial phase, because then we do one and then we can do a PCR. You can do it in one evening. So I think we need to work a little bit more on the technical implementation. It could be done relatively quick, but we need to improve. Because this is still in trial stage, it's not in the implementation stage yet. Okay, thank you, doctor. The next one. I have you said that more trials need to be done. What kind of of a test you think that need to be done right away to be able to move faster to achieve more conclusive results? That's another great question. I think that we need to find some study groups that might work, or trial groups that they need to work not only in infection but in progression. We can work with HIV groups that have been exposed, or maybe healthcare workers where we see high incidence of TB. We can also work maybe in jails. So if we can validate this, it could be great progress for us. Also, patients with diabetes, patients being treated by the biologics. So these groups will be very interesting, very important to, because we also need not only for the cohort, but we need also see the effect of the preventive treatment. I think in our countries where there is high exposition to frequent exposition, and that can occur in many cases, repetitive exposition, I think these kind of biomarkers should have this dynamics of being able to be treated and followed. And if they don't go up, it means that the patient have not been exposed again, or maybe they have, and so they need to be treated again. So maybe some of the indicators, they show some protection. That might also lead us to identify low-risk patients that not necessarily need to be intervened. So I think that's where we're going. Thank you so much, Doctor, for your participation and for answering these questions. We want to thank Bacmo and Nissan, our sponsors, and also the interpreter Claudio Valencia, who has been interpreting both presentations in Spanish into English. The English presentation can be found in RemiTV YouTube channel. And also we want to thank the YouTube, Facebook, Imagen UBC TV channels. We want to thank our CEPA friends from the UBC in Mexicali, and also all of you that are here with us today. We want to invite you to join us next week for the 7th edition, Tuesday, November 15th at 9 a.m. Pacific time, where we're going to have the participation of Dr. Rogelio Hernandez Pando, who is a researcher and the experimental pathology clinic by the medical science hospital in Mexico City, who will be talking about neuroimmunoregulation and experimental TB. And also we will have Dr. Carlos Martin, who is a researcher in the medicine school in Zaragoza, Spain, with the subject MTB back, the challenge of improving protection to transmissible TB after 100 years of BCG usage. So if you want to get the attendance certificate, you just visit www.remitv.org. You can follow us on our social media, YouTube RemiTV, YouTube Divulgare, USA Jersey UBC, and Facebook RemiTV. Have a wonderful day. Thank you.